right.
Okay, so ladies, thank you so much for joining. We have Dr. Petrokovsky today that is going to be presenting to us. So the main reason for our conferences that we're going to be creating is to help everybody get some basic knowledge
Hello,
on
how are you?
what we do in the office. Hello. So one major thing that we're seeing is there have been recently a lot of people a little bit hesitant when it comes
Sorry,
to
she's doing a meeting.
Dr. Petrokovsky is going to go through,
Yeah, we're on.
some basic information on different things that we need to realize when we're seeing patients who are OB. We want you to feel comfortable. We want you to feel supported and understand that these patients are just like any other patient. They're going to need, a similar approach to care. As long as you just follow the timeline of what needs to be done, everything usually goes into line. So, we'll go over certain milestones, certain things that are very important to maintain and watch over patients during obstetrical care. And we don't want you to feel intimidated or scared. We're OBGYN, we're going to see patients coming in for GYN and OB concerns. So we want you to feel comfortable with seeing also your obstetrical patients. And down the line, I think I could say comfortably that this will probably be easier than many of your GYN cases. But from that point on, Dr. Petrokovsky, I'll let you take over to go over a little bit about prenatal care. I mean, we can cover as much as we can, maybe first, or even go into second trimester just to get the basics for all of our PAs and nurse practitioners.
All right.
Thank you so much for doing this for us today.
Listen, it's a pleasure. Good morning, everybody. Welcome, everybody. Well, I will not be saying anything new to you. It's just a basic review of the pregnancy management. And we're talking about pretty much low-risk pregnancy or regular patients. I think that both the healthcare provider and the patient needs to be comfortable. And in order to be comfortable, you really need to know what to expect when you're expecting, sort of, because I think it's very important. If the patient is well informed on what the next step is, and obviously if the provider is comfortable to go over every step of the pregnancy, then usually there is really no issue and everybody feels good and comfortable. Now, what's also important is that, at least in our practice, we really need to be very clear that if the patient has a high risk factor, which by the way could be temporarily, nobody is stuck to high risk label. For example, there could be high risk factor for the first trimester of pregnancy, such as retroplacental blood clot, especially significant. So they come, they see a perinatologist, we discuss it. But the very moment the clot is gone, the patient is no longer high risk patient, and she goes back to her regular physician, or there is no need for co-management. So I think it's very important for the patient to be comfortable with that concept, that maternal fetal specialist is sort of on guard, is in case something goes not the way it should be, and it doesn't have to continue throughout the entire pregnancy. Because I think it's very scary, the patient are very scared when they labeled high risk. So we explain to them that high risk factor may disappear or may appear at some point later in pregnancy, such as cholestasis of pregnancy, that is usually a third trimester issue. So somebody could be perfectly normal in the first and second trimester and then develop a complication such as cholestasis or preeclampsia or severe anemia later in the third trimester of pregnancy. So I think it's very important for us to understand. Now let's go to the first time you meet with a patient. Usually it's missing menstrual period or feeling uncomfortable, feeling nausea or something of that nature. We usually start with the base labs. And this is beta ACG. Progesterone is optional, and those are the whole bunch of prenatal labs that are pretty routine. Regarding thyroid studies in pregnancy, it's pretty controversial. Some doctors feel strongly that they should look at them. Some people feel that it should be done only if the patient has any previous history of thyroid problem. And actually, I belong to the second group. I don't think that everybody needs to be checked for thyroid profile in pregnancy, because a very borderline changes may take place, especially with progesterone surge in the first trimester of pregnancy, and that could be very confusing. So clearly, the first question when you see early pregnancy is to make sure it's a normal pregnancy. And here is the issue about ectopic pregnancy. We need to always think ectopic until proven otherwise, because ectopic pregnancy till now remains, I would say, one of the major cause of maternal morbidity and even mortality if mismanaged or missed. So clearly the documentation of fetal heart or fetal pole within the uterus is really crucial when it comes to the first trimester of pregnancy. Obviously, you look at the potential for molar pregnancy, blight on ovum, or any abnormalities in the development of the fetus at this stage. Now, this is a sort of slide that we usually show to medical students that shows you various sites of ectopic pregnancy. Obviously, tubal pregnancy is pretty much the bulk of the ectopics. Corneal pregnancy and cervical pregnancy, honestly, are very difficult to diagnose precisely. If you see implantation very hard, very high in the uterus or very low in the cervix, you may be suspicious of the corneal or tubal or cervical pregnancy, but very often it's the onset of miscarriage. If I see very low location of the fetal pole on the prenatal ultrasound, my first thing is miscarriage. And obviously, I think about cervical pregnancy, but that's still a very rare abnormality. So clearly, you really need to make sure that the pregnancy is located in the right position. Otherwise, it becomes an obstetrical emergency. Now, let's talk about the early first trimester. When the patient comes and you look at the beta ECG, you actually establish that the pregnancy is inside the uterus. Then you discuss basics on nutrition, behavior, exercise, and because obviously, especially if it's a first pregnancy, patients have a lot of questions. And this is when you really spend most of the time with them trying to answer all the questions. The very common complaint or very common concern, I would say, that they will tell you that they were taking certain medications such as Tylenol, aspirin, sleeping pills, you name it. And there was a very interesting study published a decade ago that said that overwhelming majority of women were taking some medication, including birth control, unaware of the fact that they were pregnant. So it's very common. As a matter of fact, more women do take various medication, they don't in anticipation of pregnancy. And the good news is that the overwhelming majority of those medications are completely benign. So patients obviously needs to be reassured that the majority of patients, if they don't belong to those allowed in pregnancy formally, which is only vitamins, that the likelihood of any damage to the fetus is minimal to none. So reassurance is really very, very important. Now, on the first obstetrical visit, obviously you register the patient, you go through medical history, including obstetrical and gynecological history. Family history is very important because here you talk about various genetic diseases in the family, in the partner's family. So that's really the most time you spend with the patient. Health education, we use a lot of various pamphlets. You can discuss immunization, or at least make sure that immunizations are appropriate and registered in the chart. This is pretty much, at this point at least, I usually tell them how often, provided the pregnancy is low risk, we will see them. Because first of all, they need to make their plans. They need to know what to expect at various stages of pregnancy. And you can see this particular table is very clear. From the very beginning of pregnancy till about 28 weeks, you see patients usually once a month. Starting from 29 weeks to 36 weeks, provided the pregnancy is normal, you do every 2 weeks. And starting from 36 weeks until birth, you see them weekly. And obviously, at that point, we more concentrate on the fetal well-being and fetal status. Well, this slide, I will not go into every details, but you can see that the most drastic change in the fetal appearance and fetal growth has taken place from the very beginning of pregnancy till about 12 weeks. You start with a fetus that is a size of a quarter of an inch, and you go by 12 weeks, you can pretty much assess main structures of the fetus. So at this particular time is really very crucial to understand what goes on with the fetal development. By the way, there is a lot of pictures, websites, and cards, and patients are always interested to see what goes on with the baby at various stages. So you can always use this material, very illustrative material. Let's say when they come at 12 weeks, I sometimes show them a 12 weeks fetus, so they know exactly what goes on inside. And you go into details of various organ development. Obviously, most patients are interested somehow in the brain and genital area, so you address both of them. And then you go into other areas and aspects of fetal development. And this is pretty much what we say to the patient, that usually around 5 weeks, we detect the heartbeat. Then you see the development of extremities, internal organs, including heart, brain, pancreas, etc. You can see the eyelids and pay attention of the eyes, hair, fingernails, etc. So this is something that obviously may not be that important clinically, but patients are usually, especially their spouses, are very interested. They would like to look at the ultrasound pictures, and they would like to see what goes on with the fetus. They call it baby. I still prefer to call it fetus, because if there's any problem in the first trimester, at least mentally, I think it's much easier to lose the fetus than to lose the baby.
Now, Dr. Petrakowski, I'm so sorry to interrupt. Two
sure,
providers,
you can interrupt anytime.
Connection, if we could admit them.
Good.
A couple providers lost internet connection, and they're trying to get back into the meeting. Do you see anything about admitting?
I don't see anything on my screen.
No? Okay.
No. I see only prenatal care. I don't see anything on my screen.
Okay, no problem. We can continue. I'll share it. Maybe later on, I'll just share the video for anybody who missed it.
All right, no problem. So those are, I would say, an important factors to review with the patients. Well, listen, I would say something that I never say to the patient, but if you ask me if pregnancy is normal condition, obviously everybody will say yes, because most of us are mothers or fathers, so at least consider it. And we consider pregnancy is a normal stage of women's life, or couple's life for that matter. If I ask you, for example, if appendicitis or hernia is a normal condition, you will say, no, it's a disease. And that's correct. But on the other hand, the morbidity and mortality from pregnancy, at least 3-5 times higher than of those surgical emergencies. So it's really a balance. On one hand, you need to keep patients very comfortable. On the other hand, you need to make sure that they follow and report certain signs and symptoms. They may lead to a problem. So clearly, on the important facts to review in the beginning, you talk about heartburn, you're talking about changes in the body, you talk about vaginal bleeding, you talk about morning sickness. As a matter of fact, you see in the end of this slide is birthing plan. We actually published a small interesting paper a while ago showing that the birthing plan that they spend so much time looking at usually is really a waste of time, because once pregnancy ends up and somebody plans natural delivery, ends up with a C-section and the other way around. But I think it's very nice if patients have time, sit down and just discuss birthing plan or at least options with the healthcare provider. Now, this is routine labs that we do. I just want to show it to you one more time. Obviously, based on the family history, you look at the potential for various genetic disorders. I'm talking about sickle cell anemia in African Americans. You can look at thalassemia in Italian Americans. You can look at Jewish Ashkenazi panel and things like this. So here we're clearly not born equal, and depends on the background, you somehow navigate the plan of management and the plan of screening. Clearly, cystic fibrosis and Fragile X are pretty much universal for many patients. Now, this is the very usual, very routine first trimester checkup. I think both patients and providers has to be comfortable. We usually take patients' weight. We check the blood pressure, vital signs. We look at the fetal heart rate. We do assess cervical length, and we take urine analysis. So clearly, those are the very basic that most patients go pretty much at every exam. Cervical length is really important because a lot of preterm labor, first of all, it may occur first time. Obviously, somebody who has a history, there is a clear justification to do it. But listen, everything starts somewhere. And somebody for whom it's a first pregnancy, there's no history of preterm labor. So based on this, you will really make cervical length assessment absolutely universal during ultrasound.
Dr. Petrakovsky, I mean,
Yes.
one thing before we go into the nuchal translucency, frequently we'll see patients coming in an early stage pregnancy, and we find on ultrasound subchorionic hematomas. How can we assure patients, how to...
Say it again, I lost you. Hello?
Manage this, and our providers that are able to explain patients looking out for.
Can you hear me? Because I think we have some technical difficulties. Could you please repeat the question?
Yes, can you hear me?
Yeah, I can hear you now. Yeah.
Okay, so my question was, if we could just review with the providers on the conference, subchorionic hematoma. This is a very common finding, and I frequently get messages from our PAs and nurse practitioners about how to manage patients with a subchorionic hematoma. And I guess just maybe education that we can provide to the patients on signs and symptoms, when to worry, when not to worry.
Well, subchorionic hematoma occurs in about 5 to 7% of all pregnancies. And the outcome is usually absolutely benign. It's a sonographic diagnosis, but some patients come complaining of bleeding or cramping. The outcome in subchorionic hematoma depends on the size of the hematoma and location. If it's located closer to the cervix, then there is more likelihood of external bleeding. If it's in the middle of the placenta, further from the cervix, you can see it on the ultrasound. There is more chances for cramping, and bleeding may not be there at this point. The outcome, as I say, is usually very favorable unless subchorionic hematoma is a very large size. I would say take about from half to 2/3 of the placental surface. So we usually try to make patients comfortable. Now, there is really no scientific guidelines for it, but we try to be on the safe side. We recommend pelvic rest, but not bed rest. We recommend limited exercise, and we follow the hematomas on the ultrasound, and usually within 2 to 4 weeks, they're completely gone. Sometimes with bleeding and sometimes without bleeding. So pretty much subchorionic hematoma is something that we see, I just try to summarize, quite often. And it's something that in the majority of cases, unless it increases, or if some sort of patients with hematologic disorders or bleeding disorders or low platelets, then that's an issue. But then the hematoma is a sign of hematologic disorders. But if nothing else is present and CBC is normal, is usually pretty encouraging. The only thing is, don't forget to ask patient not to take medications such as aspirin that will increase bleeding. So any medication that will somehow increase the bleeding potential is discouraged for the presence of the hematoma.
Thank you so much.
Anyway, now we're talking about nuchal translucency. Nuchal translucency, as you know, remember the slide I showed before, how fast the fetus is changing during the first trimester? That's why timing is crucial. So here we say we do it between 11 and 13 weeks of gestation. It's actually a screening test for Down syndrome, for trisomies, and congenital heart disease. Our technicians, our sonographers, in my experience, are excellent in measuring nuchal translucency correctly. So we really don't have much problem with this. So that's something that is part of the early genetic screening. The very common question that I would like to answer, and I would like you to be comfortable with, let's say if nuchal translucency is increased, but everything else is negative. There is normal heart, and the genetic testing, whether we do it by assessing fetal cells in maternal circulation, are normal. Then the prognosis is usually benign. We still follow up because we don't want the baby to develop hydrops later on, but the chance of that is very low, is probably less than 2-5%, depending on the literature, and the usually outcome is favorable. So it's very important somehow to discourage patients from anxiety because they hear that they have increased nuchal translucency. Obviously, they rush to do the testing, which is appropriate, but if the test comes back normal, I would not be concerned. I would really try to make people feel comfortable. Now, this slide shows that if there is abnormal results, you can offer amniocentesis, CVS, but now we usually pretty much start with cell-free DNA.
Okay.
Now, I will not spend too much time on cell-free DNA. It's a very good and accurate test, but it's very important to understand that it's still a screening test. So the way I usually approach this problem, if they ask me a question with increased nuchal translucency and completely normal cell-free DNA, I usually tell patient if she's comfortable with 95% and plus, then that's the end of the story. If she wants 100%, then you need to go to invasive testing. And I think at this point, in our knowledge of genetics, it's really up to the patient and family to decide. The overwhelming majority of patients will accept normal cell-free DNA results and go no further. Some patients, especially with the previous experience, or who are more concerned about the possibility of genetic disability, they will clearly go for more testing, and then you offer them either CVS or amniocentesis. Now, this is the slide that shows we're actually moving into early second trimester. And again, as I said, if you have those are not very pretty pictures, but you can find real pictures in various atlases of fetal development, just to show how the normal fetus looks starting from 14 till 26 weeks. That's pretty much the time when you see patients on the regular basis. This is after they pass all the first trimester genetic testing. Now we move into the second trimester. I will probably actually limit this talk to the first and second trimester. And if there's any interest, because third trimester is more complicated as far as potential for various abnormalities in the fetal development, placental insufficiency. We hardly ever see placental insufficiency in the second trimester and never in the first trimester. If you see any signs of placental insufficiency in the second trimester, you should always be concerned with some sort of genetic abnormality, because usually true placental insufficiency starts much later in pregnancy. Now, at this point, obviously, you discuss what goes on with the baby, baby sleeping cycles, eye opening, blinking, and those are also amniotic fluid movements, fetal swallowing, etc., etc. At that point, most moms start feeling fetal movements, so-called kick count. I'm about skeptical about the reliability of that, but you still listen to the patient. If they report decreased fetal movements, especially if before they had normal fetal movements, because this is very subjective. It's something that the patient reports. It depends on many various factors. There's definitely known cases in medical literature when the women will report normal fetal movements and they were found not to be pregnant at all. So, or the other way around, when they were in advanced pregnant condition and they couldn't feel fetal movements. So this is something that is very subjective, and it cannot be, in my opinion, at this point, scientifically researched. But you still ask patient how they feel, how the baby moves, and things like this. Now we're talking about part one of the genetic screening, and that's, here, just tell you exactly what we do. This slide shows that you can review amniocentesis. We do less and less of amniocentesis at this point because many more patients accept fetal blood in the maternal circulation. Now, by the way, I think ACOG recommends it as universal test. It used to be for high-risk patients only. So now we're much easier on that. That's something that you feel free discussing with the patient. It also allows you to determine the patient gender. Obviously, at this point, especially in a high-risk patient, you can do early genetic glucose screening. Patients with a strong family history of diabetes, patients with pre-existing diabetes, patients with large-sized babies, taken on the drugs or medication that can affect insulin resistance. Those are the ones that will look at this particular point with hemoglobin A1C and also 1 hour GTT. If the tests are positive, we actually send patients to appropriate education and discuss the management of elevated blood sugar. Now, at around 16 weeks, if you look at the recommendations here, we already start looking at the placenta location and discussing the level 2 ultrasound or comprehensive ultrasound, which, according to the slide, the optimal time is between 20 and 22 weeks of gestation. The reason for that, first of all, you can see better. You can see better the fetus at this stage. And also a lot of structures that we'll look at are pretty much developed at this particular gestational age. So clearly, level 2 ultrasound or comprehensive ultrasound is a big milestone in the management of pregnancy. because very often we detect certain abnormalities or reassure the patient that there is none of those abnormalities present. I will not go over the placenta previa because placenta previa is definitely not part of the normal pregnancy. I just want to tell you one thing when you look at the slide with various locations of placenta, that in the second trimester, there is many more so-called placenta previa or low-lying placenta compared to third trimester. It's just because there's not enough room in the uterus. So clearly, a lot of placenta locations in the first and second trimester are very low, and we try not to increase patients' anxiety by labeling them. Unless you see a complete previa, I usually don't even mention it in details, bring back in about 2-3 weeks, rescan, and see what goes on with the patient at this stage. So this pretty much, talking about placenta previa. And now this is pretty much the last slide because I want, as I said, to review the first and the second trimester now. And if there's any questions and comments we can discuss. As you can see, at 22 weeks, you already get the result of the second screening test. You get anatomy scan. And at this point, you can pretty much address most of the issues with the fetus. If first and second trimester screening are normal, and anatomy scan is of no concern, then the likelihood of fetal abnormality is very, very low. So at this point, you can really encourage patients to feel good about it and decrease the anxiety about anything that could potentially happen with the fetus. So I'll probably stop right here and then we'll continue with the third trimester next time. If there's any questions and comments, let's talk.
I have a few questions.
A little louder, please.
Oh, okay. I have a few questions. On the slide, you talked about amniocentesis, and you said that ACOG doesn't recommend doing that anymore, but what was the test that they recommend? I missed it.
No, I didn't say that ACOG does recommend amniocentesis. Let me just clarify it. ACOG's statement was that they encourage people, pregnant women, to take non-invasive genetic testing.
Okay.
That used to be limited once the first, about a couple of years ago, when the first time fetal cell and maternal circulation was reported. It was not a routine test. Most of the insurance companies will not cover for it. Now, as far as I know, at least Maternal Fetal Medicine Society recommends to discuss it with pretty much every patient, and those patients who are interested, they can be the candidates for this testing. Regarding amniocentesis, you really need to be clear that fetal cells and maternal circulation is still a screening test with a high degree of sensitivity and specificity, but it's still a screening test. Similar to the first and second trimester screening, just more accurate. So if the patients prefer to have definitive testing, then you can go to an amniocentesis or CVS.
Okay, and then the non-invasive prenatal testing, that's recommended if they're advanced maternal age, or is there anything else, any other reason why you would recommend it?
Well, they used to limit it to advanced maternal age. Now they pretty much allow us to offer to all patients.
Okay. And then
so now there's really, we used to be very limited, mostly because of the insurance coverage. As far as I know now, although I didn't go through all the insurances, but the majority of them do cover this test just because of the maternal anxiety, because the test is very reliable.
Okay, and is that the NIPT test?
I'm sorry?
That's the non-invasive prenatal test, right? That's what,
Yes.
Yeah, it's non-invasive. Yeah,
Maternity 21.
okay, so that's the test.
you just draw blood, and they try to detect fetal makeup out of the maternal bloodstream.
Okay, and then you usually do that after like 10 or 11 weeks, right?
Correct. Correct.
Okay, that was one question. And then one more question. We talked about on one of the first slides, the cervical length and how that's important, especially in early pregnancy. So for what is your cutoff for cervical length? I know, like I've heard 25 millimeters.
2.5 centimeters. It's
Okay.
not my cutoff. That's pretty much what ACOG recommends. 2.5 centimeters is a cutoff. But it's not so simple, because even if it's, let's say, 3.5 centimeters with significant funneling, which means the shape of the cervix is not normal, that's also not good, and actually allows us to look at that patient as at risk for late miscarriage or preterm labor. So it's not only the absolute measurements.
Mhm.
Absolute measurement is 2.5 centimeters. Now, if it's 2.6, I'm still a little concerned. I would like to repeat. Don't forget that cervical measurement is, I would say, very flexible one. I would not be surprised. Sometimes we tell 2.5, the patient gets very anxious, runs to the office next door, and they say 2.7. She's upset at me. I said, don't be upset at me. 2.5 and 2.7 is the same measurements. Also, because the bladder is very close, when the bladder is full, it elongates the cervix. So there's too many components, but pretty much 2.5 is the cutoff.
Okay.
But even as I said, it's more than 2.5, but you see certain opening of the cervix, then it's also put patient at risk.
Okay, and then if it is 2.5 or a measurement like that, then they should get a cerclage.
Not necessarily, because that's already like a medical decision, because sometimes you give patients a choice. I prefer cerclage, but you can also offer progesterone, modified bed rest, pelvic rest, and you remeasure it.
Mm-hmm.
So it depends on the obstetrical scenario. It's very hard to discuss it just for everybody. It's not one size fits all. But clearly, cerclage should be discussed with the patients with short cervix.
Okay. And then so let's say a patient comes in early pregnancy and they have a history of preterm labor. Do you recommend progesterone like intravaginally once a day what is your take on that?
You know, it's also, it depends when she had preterm labor, because preterm labor defined as less than 36, 37 weeks. If she delivered at 37 weeks and the baby is perfectly fine, I would probably measure progesterone level first.
Okay.
On the other hand, if she gave birth at 28 weeks or 27 weeks, then clearly there is no harm of giving progesterone and following cervix and progesterone together. So again, I cannot just tell you what to do in general, but we're pretty liberal with progesterone transvaginally, and I think we have very good results with it.
Okay. Thank you.
Dr. Petrikovsky.
Any other questions or comments?
Hi, Dr. Petrikovsky. I have a question. This is Caroline. Can you hear me?
Yeah, sure, Hugh. Yeah.
Oh, okay. It's about a patient that I have here now. So she's gravida 1 para 0 at 10 weeks 0 days. Anyways, I just did the ultrasound and I'm not too familiar with this a placental lake at 0.8 centimeters. What does this mean, and is there like any follow-up? I don't know.
Well, placental lakes is just part of the placental appearance. They usually don't require follow-up. They're completely benign. Obviously, when I see it, I like to look. You see, what you see like the black area inside placenta, which is fluid filled. but it's very important to see slow flow, because the difference between hematoma or placental lesion and lake is the presence of blood flow inside that particular lesion. So I assume if they call it lake, they usually increase the appearance, they zoom it, and they make sure that there is a blood flow inside. And usually placental lake, especially a single one, is of no significance.
Okay, great. Thank you.
Any other questions or comments? I like more comments than questions.
All right, I think that probably covers a lot of everything. Dr. Petrakowski, thank you so much. This was very helpful.
Yeah, it's my pleasure. Thank you. Have a
Right.
wonderful day, and thank you for listening to me.
Appreciate everything. All righty, everyone. See you at the doctor's meeting. Thank you.
All right.
Thank you so much.
Thank you.